I'd like to invite Dr. David Selman to the podium, please. Here he'll present the phase 1 results of the first-in-class CXCR1/2 inhibitor, SX-682, in patients with hypomethylating agent failure myelodysplastic syndromes.
Perfect. Thanks for the introduction. I hope the slides don't auto-advance, but we'll all stay tuned. These are my disclosures. So again, I'd like to thank the ASH Scientific Review Committee for selecting this abstract for oral presentation. It's really an honor to present on behalf of all of my co-authors a clinical trial with SX-682 in HMA failure myelodysplastic syndrome patients. So as far as a brief background, as maybe this pathway is not as well known, human CXCR1 and CXCR2 are closely related 7 transmembrane G protein coupled receptors that can actually be activated by 7 redundant extracellular chemokine ligands, potentially the most important being IL-8. SX-682 is a small molecule that at nanomolar potency can inhibit CXCR1 and 2 through an intracellular allosteric receptor site. CXCR1 and 2 does play an important role in normal hematopoietic processes, predominantly in neutrophil trafficking from the bone marrow, but we'll show some critical data as far as its role in myelodysplastic syndrome patients. As far as briefly prognosis, I think the audience is very well aware that the HMA failure MDS patients represent a group of patients with really the most urgent of need. And if you look across HMA therapy in higher risk patients that have failed either azacitidine or decitabine, the median overall survival is less than 6 months. And even in lower risk patients who have failed hypomethylating agent therapy, the survival is quite impacted, with the median survival somewhere less than 12 and 18 months. As far as mechanistically how impactive this pathway plays a role in myelodysplastic syndrome, a lot of this work was done by Dr. Verma. CXCR1 and 2 can play an important role both in MDSC propagation, which we and others have shown to be a critical role in MDS pathogenesis, while at the same time plays a role in LSC survival, and I'll show some more detail in a moment. So looking in a cohort of MDS patients, patients that had CXCR2 high expression were more transfusion dependent, and actually in this cohort, 100% of patients did have significant upregulation of the IL-8 CXCR2 pathway. Potentially more importantly, patients that were treated with either azacitidine, azacitidine in this study actually had significant upregulation of this pathway upon progression. And in a cohort of AML patients, higher CXCR2 expression was associated with inferior overall survival, potentially showing a role for this across myeloid malignancies. There's also additional data in myelofibrosis. Again, inhibition in this preclinically and in vitro and in vivo models was able to decrease viability of the leukemic stem cells in these patients. As far as a potential PD marker, so again, CXCR2 does impact neutrophil trafficking, so you can follow neutrophil counts for patients early on treatment. In normal healthy volunteers with a dose of at least 150 milligrams twice daily, you get sort of maximum sort of decrease transiently of these neutrophils, again, potentially serving as a PD marker as we move forward with this study. This trial was funded by the NHLBI, and again, the goal was to explore the safety and efficacy of SX-682 in HMA failure MDS patients. So today we're presenting the completed dose, the phase 1 dose escalation data. The dose escalation went from 25 milligrams BID up through 400 milligrams BID. As far as eligibility, this trial was written quite broadly to allow most patients on study, which is, again, I think it may be a critical need, again, in this patient group. All patients were greater or equal to 18 years of age and had to have failed azacitidine or decitabine with at least 4 cycles, defined as no response to treatment, loss of response at any time point, or progressive disease intolerance to therapy, and required a performance status of 2 or greater and relative adequate organ function. There was an early bone marrow biopsy done in cycle 1 to look for at correlative studies, including MDSC eradication and LSC eradication after cycle 3, and then every 3 cycles thereafter. Again, the primary endpoint was safety, with secondary endpoints IWG response criteria 2006, as well as some additional PK studies. When we look at the baseline demographics, you can see that there are a mixture of both lower and higher risk MDS patients across cohorts. Again, any IPSS risk could enroll on the study, and patients were dosed up through the 400 milligram BID cohort. As far as baseline hematologic parameters, 100% of patients were RBC transfusion dependent, with other patients having both significant neutropenia and or thrombocytopenia. 1/3 of patients additionally were platelet transfusion dependent. There was heterogeneity as far as baseline blast count, with a mixture of patients having both low and increased blasts. If we focus on the 200 milligram BID cohort, 4 of the 6 patients did not have an increase in blast. Again, all patients were HMA failure as required by the protocol, but a number of patients had prior therapy, including lenalidomide, ESAs, venetoclax, or investigational therapies. When we look at the PK across dosing cohorts, we did see further augmentation of PK parameters, both in trough and peak levels, that was optimal at the 200 milligram BID cohort. Additionally, looking again as a pharmacodynamic marker, and we again have the figure on the left in patients with normal bone marrows, as well as on the right with patients on our study. Again, at this 200 milligram BID, we sort of get this optimal reduction, not that we're trying to induce neutropenia in our patients with myelodysplastic syndrome. Again, this is a transient phenomenon that goes back to baseline early on after cycle 1 and can recover quite rapidly in patients where the dose is held. In total, based on PK and these PD data, as well as safety data that I'll show in a moment, the 200 milligram BID was determined to be the biologically effective dose and is the dose going forward in expansion. As far as the safety, again, we do expect this on-target neutropenia. 2 out of 6 patients at the 200 milligram BID cohort did have grade 3 or 4 neutropenia, and notably 2 of these patients did have febrile neutropenia. Although there were no infectious-related adverse events, no patients discontinued for treatment-related adverse events, and there was no early mortality. And again, these effects on neutrophils were otherwise quite transient. When we look at efficacy across all dose cohorts, there were no patients that responded at the lowest dose level of 25 milligrams twice a daily, but starting at the 50 milligrams twice daily and onward, we did see responses. We do color code the responses as far as green being marrow CRs, blue being hematologic improvements, as well as some additional patients had cytogenetic response. When we focus at the 200 milligram BID cohort, 3 of these 6 patients did have response, 1 hematologic improvement, as well as 2 marrow CRs, 1 of which additionally had a partial cytogenetic remission. Around half of patients did have bone marrow blast reductions, and again, I'm going to highlight a sort of exceptional patient in a moment. Again, patient 106 was an intermediate 1-risk MDS patient who was SF3B1 and TET2 mutant at baseline, had progressed after 6 cycles of hypomethylating agent therapy, but had also previously been on lenalidomide, erythropoietin-stimulating agents, and actually most recently was on a novel therapy before enrollment on this study. The patient had very high transfusion dependence at 16 units in the 7 weeks preceding enrollment on the study, and this patient was actually dosed at the 50 milligram BID cohort. This patient was on study for over 17 cycles, and we highlight their sort of exact platelet counts and RBC transfusion needs on the bottom. You can see the patient quite rapidly had an improvement of the platelet count, which is what we have seen in several patients. But from the RBC perspective, it was quite unique, potentially speaking to some of the immune mechanism of this therapy. There was this sort of gradual reduction in need of RBC transfusion dependence actually over the course of a full year on therapy, at which point the patient had over 4 months of transfusion independence with a hemoglobin of greater than 10 grams per deciliter during that time, actually very much approached 11 during this time. So in conclusion, SX-682 is a novel therapy for HMA failure MDS patients. Again, it has dual activity against leukemic stem cells as well as myeloid-derived suppressor cells shown in preclinical models and additionally in the study. Single agent SX-682 has overall been well tolerated without dose-limiting toxicity or maximum tolerated dose. Again, we saw responses at early dose levels starting at the 50 milligram BID cohort, but looking at what the current expansion dose cohort, 50% of patients had responses, albeit some of these patients were marrow responses. We did have 1 patient sort of with a durable near CR response, again, trilineage hematologic improvement, again, was heavily transfusion dependent and was on therapy for almost 18 months with transfusion independent for 4 months. Again, based on the data to date, the 200 milligram BID dose is the dose going forward. And so there's currently a 20-patient expansion ongoing in HMA failure MDS patients. And additionally, as potentially the role of MDSCs plays a predominant role in HMA naive patients, there is a 20-patient expansion that is also ongoing in that setting. Additionally, there are future combinations, including HMA combinations, that are planned in the relapse setting as we speak. So with that, I'd like to thank all my collaborators on the study, particularly Dr. Kamraji, who helped co-develop this protocol with me, Dr. DeZern, who's been closely involved for a long time now, Dr. Gale at Advent, and the whole Centrix team, and of course our patients, as well as the NHLBI for funding the study. Thank you for listening.
Standing presentation will open up for questions.
Yeah, great presentation, David. So 2 questions on the patient, the super responder, and sorry if I missed this, but what was the blast count when they went on the study, and how low did it get? And for the same patient, were they transfusion dependent, or what was their platelet count before they went on the last treatment, the investigation therapy that was before this trial? Because, did this bounce back to how they were before, or was this actually from the drug? Thank you.
Yeah, so the patient's platelet count was a baseline around 50,000, as enrollment on the study was around 30, but this patient actually rebounded, over 100. So from the baseline pre the novel therapy did significantly improve. And sorry, the first part of the question one more time?
The blast count.
Yeah, so this patient did not have increase in marroblast at the beginning. So was 3-4%, but not increased at baseline.
And do you have any hypothesis on mechanistically how would you get like the hematologic improvement without impact on the disease burden itself? Any theories?
Yeah, so we are looking at our molecular analysis right now, including sequential analysis. We also have a comprehensive flow panel trying to look at both MDSC eradication as well as LSC eradication over time. So that may give us some answers. As far as potentially baseline molecular predictors, again, very small cohorts. Out of the 5 responding patients, 3 patients had splicing mutations. 2 of those patients had SF3B1 mutations. There is potentially data that splicing mutations may further upregulate that pathway. But as far as predictors of which patients respond or don't respond, I don't have a good answer for that.
Thank you. Great work.
So I had a question. So in this phase 1 study, given the therapeutic window, which could be tough with hematologic toxicities, how often did you have to do dose holds, delays, and how did that impact time on therapy?
Yeah, so all of these patients had continuous dosing through the DLT window. I would say approximately half of patients, I don't have the exact numbers, potentially had intermittent holds at a subsequent cycle. Usually they only had a one-time hold, and upon recovery back to their baseline, were able to stay on. All patients did go through 6 cycles of therapy without patients kind of urgently, coming off for any treatment-related adverse event. So dose holds were not infrequent, potentially cycle 2, cycle 3, but typically we're back to baseline and did not require holding thereafter. But I think, going forward with this continuous dosing, again, should these patients get, intermittent breaks, I think what's the optimal dosing strategy could, potentially still need to be answered.
I noticed that the median ANC was actually pretty darn good for an HMA failure group, and I'm curious to whether or not these were predominantly those that had lower risk, that were HMA failure. And now that you're moving, I think, towards expansion, will you look at lower versus higher risk HMA failure separately?
Yeah, so we have 2 planned cohorts. Again, one HMA naive and one not. There's no there's no specific requirement for a certain number of lower or higher risk patients. Although I think that analysis is important. Again, it was kind of heterogeneous across cohorts, particularly at the 200 milligram BID cohort. There were more patients that were lower risk, and potentially a little bit of a bias in the fact that maybe that group of patients may be most sensitive, especially if MDSC eradication is sort of a key component of the mechanism of action.
So just from the preclinical data, just from the preclinical data, was there any correlation with any particular subtypes with CXCR2 signaling that you'd seen? Because this is obviously the clinical, but
So, I mean, Dr. Verma, in the audience could speak, but no, I don't. I mean, at least in their blood paper back in 2015, there was no specific subset. I think they did see in patients with HMA failure further upregulation of the pathway, but I don't think as far as a baseline predictor for which patients may have this. They said it was sort of uniform across their entire cohort, but whether or not there's differential upregulation based on molecular subset or other feature, I think is a good question.
Thank you very much.
Thank you.